Yeah. Welcome to my channel. Adeshola Onide is my name. In this channel, what I do is to give you learning tips. And sometimes I pick topics in biology and medicine and discuss them in a very simplified manner to aid your study. Always ensure you visit this site regularly. Thank you. Hey guys, if you are new in my channel, please kindly click on the subscribe button to encourage me. Thank you. Still talking about gastrointestinal disorders. Remember, in my previous video, I talked about Zolling-Ellison syndrome. If you have not seen the video, I think you should check it out. You will really like it. However, in this edition, I'll be talking about Verner-Morrison syndrome. Verner-Morrison syndrome, also called a vipoma. Get a seat. Ensure you are very relaxed. I can assure you are going to enjoy the video. So call it WIDA. WIDA syndrome, WDHA. The WIDA stands for the common presentation. W, watery diarrhea. WIDA, watery diarrhea that will result in dehydration. That's WD, watery diarrhea and dehydration, resulting in dehydration. H, hypokalemia and hypotension. A, achlorhydria and acidosis. Also, of course, the H can even be H raised to power 4. Hypotension, hypokalemia. Then we have two hypercalcemia and hyperglycemia. All right. You will soon realize how we get all those. All right. Now, note something about vipoma or Verner, V-E-R-N-E-R, Verner-Morrison syndrome. The problem is we have VIP producing tumor, which are commonly present in the pancreas. Note that this vipoma is the third most common neuroendocrine tumor of the pancreas. Third most common neuroendocrine tumor of the pancreas. It is usually solitary in the body or tail. It's not like it's everywhere. It's usually solitary, found in the body or tail of the pancreas. 2/3 of it is malignant. So majority of it is malignant. It's not a benign tumor. Male to female ratio in children is 1:1, but male to female ratio in adults is 1:3. So meaning in adults it is commoner in females than in males. All right. Another thing that you should know about this vipoma is the fact that the presentation is actually as a result of VIP that is produced in excess. Now, when you have this at the back of your mind, then it will be easy for you to understand what vipoma is. We have said that majority of the vipoma arise within the pancreas. Majority arise within the pancreas. We can have some also coming from the lungs, one, from the colorectal cancer, and they can also be a few chromocytoma of the adrenal. Now, the common age is between 30 and 50 years. That's the common age at which people develop it. Of course, we also have it in children 2 to 4. Remember, I've told you that those that are in children, male-female ratio is 1:1. But in adults, male-female ratio is actually 1:3. Another thing you should note is the fact that it is 60% of it that is solitary and it is found in the tail of the pancreas. 60 to 80% of it found in the tail of the pancreas. Vipomas have tendency of metastasis. They can move to different parts of the body. Then usually they can also be, they are sporadic and they can be isolated tumor, but they can be part of men type 1, just like gastrinoma. You can see that this men type 1 is very notorious. Gastrinoma is also part of the men type 1. Now, I've told you that the symptoms or the problem is actually due to excessive, unregulated secretion of VIP tumor. This tumor produces a lot of VIPs. And we have receptors of VIPs everywhere in the body. Now, the effects will be that this VIP will bind adenylate cyclase Adenylate cyclase will activate cyclic AMP production, and this will result in accumulation of fluid and electrolyte within the lumen, so resulting in secretion. Don't forget, I've told you the basis of diarrhea is actually if there is imbalance between secretion and absorption. So meaning either there's a reduction in absorption or there's excess secretion. So the problem here is actually excess secretion. Don't forget there can be diarrhea in Zolling-Ellison syndrome too. But in that case, the problem will be absorption because of the ulcer. Can you get it? So know the link. In fact, it might not be a bad idea if one do comparison between the Zolling-Ellison syndrome and vipomas. Now, let's look at the clinical features. Onset is insidious. I've told you it's only less than 10%, actually about 5%, that is associated with men type 1. The stool is colorless and odorless. Why? Because there's no infection. It's just that there's excess secretion. It is excess secretion that is resulting in diarrhea. Now, because of excess secretion, what will be the effect? Then that means we are losing water. Because water that should be absorbed, they are now what is being lost in diarrhea. So we are losing water, we are losing sodium, we are using, anytime you are losing sodium, the implication is that you will be using chloride too. Sodium and chloride, they always move together. So body is losing water, body is losing sodium, body is losing chloride. And this is what is going to result in volume depletion. Volume depletion is the cause of dehydration. Dehydration, volume depletion, they are the cause of weight loss. Note, anytime there's hypotension, an individual is also at risk of acute tubular necrosis that can result in renal failure. So you are seeing how we are going to investigate. The problem now is excess secretion, excess loss of water in stool. Because of excess secretion and excess loss of water in stool, there will be excess sodium. Water is always lost. Sodium always accompanies water reabsorption. Excess loss of water, excess loss of sodium, excess loss of chloride. All these result in volume depletion and dehydration. This can result in acute tubular necrosis, renal failure, then weight loss. Also, there's excretion of large amount of potassium and bicarbonate, and all this will cause hypokalemia and metabolic acidosis. Now, common thing that is seen is because of all this, we might have abdominal discomfort and bloating. So what are the laboratory investigation? Of course, you can know what the laboratory investigation will be. Serum potassium, what do you expect to say? Hypokalemia. Serum chlorine, what do you expect to do? Hypo. pH level, what do you expect to see? Metabolic acidosis. Calcium, what do you expect to see? Hypercalcemia, hyperglycemia. What about sodium? Hyponatremia. If we do electrolyte urea and creatinine, it will be elevated. Electrolyte urea will be elevated, creatinine will be elevated. You know the reason, because of the liver involvement. Because of the acute tubular necrosis that can occur, that can result in renal failure. Then there will be abnormal liver function. If we should try and check the plasma VIP assay, it will also increase. If we do imaging, we will actually find a VIP secreting pancreatic polypeptide tumor. A vipoma that is secreting VIP can be seen if we should do imaging. But note that these vipomas can also secrete other hormones like pancreatic polypeptide, calcitonin, and neurotensin. Now, this calcitonin also account for the reason why there is hypocalcemia. Where there is this calcitonin will also account for why there is hypercalcemia. All right. Now, how do we manage them? You correct electrolyte imbalance. Then the medication that can be given is octreotide acetate. Why octreotide acetate? Because we have realized that can actually regulate diarrhea. It's a somatostatin analog. So what it's going to do is going to act against, is going to analog that helps to decrease release of GIT hormones generally. Remember, when we talk about somatostatin, we said they reduce somatostatin generally reduce GIT action of GIT hormone generally. They act on gastrin, they work against gastrin, they reduce pancreatic secretion, they reduce secretions generally, and there can also be surgery, resection. We go to the tail of the pancreas, we cut away that part. Then there can be radiotherapy. So that's all we need to at least basic thing that you need to know about vipoma. The next thing we should talk about is the carcinoid disease. Thank you for watching this amazing video. I am so honored.